Screening in low-resource settings and feasibility of implementations of HPV vaccine in the community. Ma'am, we request you to illuminate your experience at Adyar Cancer Institute.
Good afternoon, all of you. It's a privilege to be here, and I thank the organizers for this wonderful opportunity. In the next 20-25 minutes, I'll just give a rapid presentation on what we are doing on behalf of Preventive Oncology, or prevention and early detection work in women's cancer at the population level. So Dr. Shanta has given a detailed data on the cancer patterns in the country, in the state today morning. So I'm not going in detail on the data. This is just an overview of cancer control activities that's happening in the institute. So Cancer Institute has been the pioneer in first population-based cancer survey in India. So that was done as early as 1961 by none other than Dr. Shanta herself. That formed the basis for the WHO cancer project, but unfortunately it took 20 years for the government to formulate a national cancer control program. That happened in '85. After many projects with and without collaborations with the government or NGOs, the recent major milestone is setup of a statewide cancer registry. So with collaboration of the Tamil Nadu Health System project, the Cancer Institute has established a statewide cancer registry in 2012, which is the largest cancer registry in the world. So the Division of Preventive Oncology in the Institute is functional since 2008, and the major undertaking is we conduct community-based screening programs, especially for the common accessible cancers, women-centric cancers, and we also train teams from across the country, from across the state, where we can set up local primary cancer care centers so that the women get awareness, education, and basic cancer care services at their locality. We also conduct epidemiological research and studies. I'll just put you through. So how do we go about the community-based screening program? After getting the necessary permission, we choose a district. We identify a local center. We partner with local stakeholders, and we identify a district, enumerate the villages, enumerate the eligible women, and we offer screening for oral cavity, breast, and cervix. For cervix, we are at present offering visual tests, sometimes cytology as a part of training in and around Chennai. We have also started offering HPV DNA as a primary modality, clinical breast examination for breast, and visual examination for oral cavity. Regarding oral screening for women, we just offer a visual examination for all women, tobacco cessation education. As Madam said today morning, tobacco chewing as a habit is coming down. What we find in the rural areas like Viluppuram is women use snuff, not only for inhalation, but also whenever they get a dental caries, they have the habit of stuffing their caries teeth with snuff powder. So as you can see, Viluppuram, still there is a high prevalence of tobacco use among women, 11%, which is highest. For breast, we are not doing much at this point of time. We are in the process of continuously creating awareness, teaching self-breast examination, etc. Clinical breast examination is offered, and we offer baseline mammogram and imaging for all women above 40 years of age. In the community, when we tell them, like, you can avail a free mammogram and ultrasound at the institute, and you can drop in any time without an appointment, you will be done a mammogram. There are not many takers. The one thing is they are asymptomatic women. They don't want to come all the way to the Cancer Institute to get a mammogram. So the takers is very less. It is around 7%. We did a pilot study in 2011 to see if ultrasound can be used as a primary screening tool for breast cancer. So it was a small study. We enrolled 439 women of about 30 years of age. And a sonologist would visit the community twice a week. So there, when we refer the women, they were very happy to avail the free service. The free scan was attractive to them. So there was a 85% compliance rate. Two days a week. It is not that every day the sonologist was there. Again, it was a referral, but the service was available in their locality. So that formed the basis for our Mammo mobile project, and it's almost everything is ready. We'll be launching this Mammo mobile project where mammogram and portable ultrasound machine is available. By maybe around March 8th, this Women's Day this year, we would be launching this program in Viluppuram. So I'm just going to give basic data or basic activities we carry out in the department with regards to the cervical cancer. Actually, we have done something in that front compared to oral cavity and breast. So if you see the compliance rate for screening, like Dr. Reddy was also mentioning in the morning today, the compliance is the greatest challenge. Even if we offer free services, women don't come forward to get themselves screened. You can see it is around 40 to 45%. And until now, we have been offering visual test via visual inspection with acetic acid and Lugol's iodine. Our positivity rate is slightly high, 20.6%, because we always have training teams and they are in the learning curve. If you see the pre-cancer detection rate, it is around 5 per 1,000 women screened, that is CN2 plus disease. And after detecting a CN2 plus disease, if we ask the women to come for treatment, not all of them come. Less than 50% of women come for treatment. So just to look at the challenges when implementing WIA, though the visual tests have been accepted as the standard test for low resource setting, we face quite a number of challenges. So one is the subjective, it is a subjective test. Continuously training the health workers, retaining the trained force has been the huge challenge. Reproducibility is again a problem. And whenever there is a huge, when the test is very less specific, when we want to pick the women, when the women's compliance is also very poor, if you don't have a very good referral system, then the whole, the basic screening becomes a failure. So we should have a strong referral system. We should know which women to call for follow-up, because we should remember they are asymptomatic women and they don't want to come, especially to a cancer center, and get themselves tested. See and treat has been an option. There are good studies which say that it has impacted cervical cancer incidence and mortality, but as Institute's policy, we prefer to have a biopsy, call the women, and then treat. So just to show why VIA is a challenge, you can see in all this, in the first figure, anyone can say it is a VIA positive lesion. It is very well in the transformation zone. And the second one, yes, it is positive. The third one, it may be referred as a cervicitis or a villi positive. And the last one, yes, anyone can pick up. So generally, the health workers pick up these lesions, and anyone who has experience in the VIA screening will know that all these are yearly lesions. As a gynecologist or as a clinician treating these women, what I would wish is, I want patients who have these problems to be referred. You can see a coarse mosaic there. Even though there is no acetowhite area, she has a disease, maybe a CA in 3 or CA in C2. So this is another acetowhite area which is within the transformation zone. And this is an endocervical lesion. That is, the lesion is within the endocervical canal. And here, there are few atypical vessels. Actually, we don't see any acetowhite area here. So if a health worker can pick up these lesions and send to me, I would feel happy. But all of you will agree it is difficult to identify these lesions without a colposcope. And if you take the last one, the atrophic cervix, again, it is a major challenge. So as you can see, all the VIA positive lesions, you can see the CAN1 pickup is high. Whereas in VIA negative group, still we get a lot of high-grade dysplasias. So this has been the reality, and we have been struggling to close this gap using visual tests in low resource setting. So this has been the roughly what we have achieved over the past 4 years. So as I said, the treatment rate is less than 50%, even though we are able to detect around 6 high-grade dysplasias per 1,000 women screened. Another major challenge is the complaints to screening. So around 2008-9, when we started in Kanchipuram district, the complaints was around 23 to 27%. That is, if we invite 100 women, eligible women, that is above 30 years of age for screening, only 23 or 25 women would turn out. Recently, around 2012-13, we could feel a slight change in their perception. Women wanted screening, they started coming on their own. So the complaints gradually is increasing and still increasing, and we wanted to investigate the reason behind that. And we could very well sense that the media campaign by the Tamil Nadu Health System Project has played a major role in bringing the women for screening. So we ran a sample questionnaire asking the women like what made them to come for screening, and most of the women responded that we saw the celebrities like the serial actors, Devyani or Ramya Krishnan, coming and telling in TV that cervical cancer can occur to any women, and so we wanted ourselves to get screened. This was the commonest response. So we learned that TV campaigns and increasing awareness is going to be the solution. So compliance is the greatest challenge, and being a low resource setting, going beyond a visual test is still a major constraint for us, because preventive oncology is not a revenue generating department. We keep spending from the Cancer Institute, so we are dependent on funds from external sources. So to overcome the challenges with visual test, we started looking at HPV DNA testing as a screening tool. Though cost is a major constraint, we thought we will run a pilot project and see if it works. So we tested 1,300 women with a hybrid capture 2 between 30 to 54 years of age, and as you can see, 350 women were either positive for HPV or WIA. So the HPV DNA testing showed a sensitivity of 84% and specificity of 50%, whereas WIA and WILI showed a sensitivity of 63% and specificity of 33%. Specificity has been a problem with both the tests. So to also test self-sampling with vaginal self-sampling with HPV DNA, we tried using this elute cartridge. It's a filter paper from GE. But what we learned was women were not forthcoming to do a self-sampling. At least we need a lot of sensitization, lot of education to the women. They had many fears, like what if the sampler breaks and gets stuck inside my part? What if I take from the wrong part? So that was a challenge, and finally all our health workers had to take the sampling. And if this works, still replicating the program in remote areas is a possibility. So we also ran a prevalence study, HPV high-risk prevalence study in Kanchipuram district around 2010-11. And we found the prevalence of high-risk HPV around 12.7%. And you could see the commonest types were 16, 52, 58, and 35. Actually, we designed a longitudinal study to follow up the women for at least 5-7 years and to see who are the women who persist HPV DNA and therefore at risk for cervical cancer. But again, compliance was the greatest challenge, and we could get only 70% of women at the end of 12 months. The persistent rate was around 29%. This is the first available data in the country, and this will be published soon. And you can see HPV-16 was the commonest type, and it was the commonest virus to persist also, more than 50%. So this is the population, this is the age composition. And as you can see in this graph, those are familiar with this HPV prevalence study in southern India. A similar study was done in Dindikkal, Ambalikai around 2005-06. And Dr. Shankar Narayan also showed a similar graph where the HPV persists in the later years, that is between 30 to 50 years. If you see in the Western countries, there's a spike in the younger age and it steeply falls. But in the rural study in Dindigul Amblikai, there was a plateauing between 30 and 50 years of age. So here also you can see 13.8, 13.2, 13.1, the middle age. So the slow clearance is one of the explanations or reasons behind the high incidence of cervical cancer here. So these are the persistent HPV types. You can see 16 and 58, they are slow to clear. So in southern India, we have these established HPV patterns. So this is the first is the Chennai study, which I just showed you, 16, 52, 58, 35, and 18. In 2003, Dr. Rajkumar has conducted a hospital-based study. His pattern also was almost same, 16, 18, 35, 52, and 58. But the Dindigul study showed a very different pattern, 16, 56, 18, 33, and 35. Only 16 is the overlapping virus here. Actually, our study was in agreement to Clifford's meta-analysis, where he said in rest of Asia, 52 and 58 are common types next to 16 and 18. We also tried to analyze the socio-demographic and personal characteristic which was responsible for this persistence, but we couldn't find any, and none of the studies show any correlation. So the next major goal of the Preventive Oncology Department is establishing satellite screening centers. This is to, actually Dr. Shanta used to say, like we should have one screening center in each district. Now, having established the statewide cancer registry, the next follow-up, the sequel should be to establish screening centers so that we can really have an impact on these common preventable cancers. So affordable and accessible, we can continuously create awareness. We can teach women that you should get yourself tested, get a pap smear done, get a mammogram done, get a clinical breast examination from expert. We can continuously educate the women. But where will they go? Where are the services? How many trained experts are there? Getting a cytology done in a remote area is a greatest challenge. That is a learning we have actually after satellite screening centers in remote areas. So now we try to identify local stakeholders and doctors and nurses, and we are trying to establish at least one team per district. So this, in Viluppuram, we have already established a permanent cancer center. You know, Viluppuram is a high incident region for cervical cancer. It is a backward district situated around 200 kilometers southwest of Chennai. We have a target women of 1 lakh, and it is more of an organized screening. The interesting point to note here is, we have been continuously using a voters list and using a census, population census list. We are continuously trying to reach the eligible households. Our social workers go into the villages. They go from house to house, door to door, and collect the details. WHO says, like, to have an impact on the disease, at least 80% screening coverage should be there. But in spite of our concerted and sustained efforts, what we are able to achieve is, we are able to cover only 48% of the women. There are various social demographic features for that. Most of them migrate outside the village for work, or they are not available on the particular day. So at the end of a screening program in a village, we are able to screen less than 50% of women. So there again, it's a struggle to have an impact on the disease. Also in Viluppuram, we are trying to implement HPV DNA as a primary screening test. So we ran a pilot study, and we found that the CARE HPV by Caregen is working good. The major advantages, the disadvantages of cytology can be overcome here. You can see our health workers are trained. This CARE HPV test can be carried out in a very simple setup, a clinic-like setup, no sophisticated laboratory, no trained experts are required. So we have just started this program, and nearly 5,000 tests we have run, and we are just waiting for more solid results so that we can make it as a demonstration program. So again, we have started implementing HPV DNA in cancer control. The next huge challenge is vaccine. There is no policy as of now. again, the women at the highest risk have least accessibility to this vaccine. So we again have designed a pilot program in Viluppuram, and we are waiting for the government's